Good afternoon, everybody, those who are here in person and those who are online. I'm Steve Higgins, and I want to welcome you to the February session of the Vermont Center on Behavior and Health lecture series. And we are in for a really good one here. But in way of housekeeping, I wanted to give you a heads up that we will not be having a lecture during March, and the reason is a practical one. So many of us will be at the SR&T meeting that month, so we just thought we would pick up again in April. So we will today we have Erin Winstanley, as you see on the slides here, who is just an outstanding investigator and scientist. And I'm going to have Eli Klemperer come up, and he's prepared an introduction.
Hi, everyone. As Steve said, thanks for joining in person, and those of you online, great to be here. We're really excited to have Dr. Winstanley come talk today. Erin Winstanley recently transitioned from the Department of Behavioral Medicine and Psychiatry at West Virginia University to the University of Pittsburgh, where she is a professor of medicine within the Center for Research on Healthcare. She received her doctoral degree from the Johns Hopkins Bloomberg School of Public Health, and her postdoctoral training was in behavioral pharmacology, where she worked with both Maxine Stitzer and George Bigelow, who, for those of you who are not familiar, are giants in the field of behavioral pharmacology. After postdoc, she went to the University of Cincinnati as an assistant professor in the Department of Psychiatry and Behavioral Neuroscience, where she began her productive career as an independent NIH researcher. In total, she has over 25 years of experience as a behavioral health services researcher. Now at the University of Pittsburgh, she is PI on the Appalachian node of the NIDA Clinical Trials Network and a member of the Tailored Retention and Engagement for Equitable Treatment of Opioid Use Disorder and Pain Study Team, also known as the TREETOP study. Currently, her research focuses on reducing the morbidity and mortality associated with the opioid epidemic, as well as the use of technology to improve access and quality of behavioral health services. She has expertise in rural health, clinical trials, patient-reported outcomes, and health policy. Her work is committed to discovering and implementing evidence-based strategies to improve health outcomes for individuals with behavioral health problems. She has extensive experience working with trainees, clinicians, community organizations, and key stakeholders. So we're very excited to have Dr. Winstanley come talk today and give her talk entitled Overdose-Related Compassion Fatigue in Rural Communities. I'll hand it over to you. Thanks. One last note, for those of you online, please enter your questions in the comments section. We'll be reading those off after Dr. Winstanley's presentation for a Q&A session. Thanks.
Well, thank you so much for the kind introduction and for the opportunity to visit with you today. I'm not sure how many of you have been to West Virginia, but West Virginia does have the newest national park, the New River Gorge, that was recently announced. I think it was about 2 years ago now. So if you were to visit that region, you would see this picture here is from Lindy Point. It's near Blackwater Falls. It's a really spectacular place to visit should you find yourself in West Virginia. So the learning objectives today for my talk is to define overdose-related compassion fatigue and to review factors that fuel such compassion fatigue, to describe some of the strategies to build individual and community-level resilience. And I'm going to talk about an applied example of some work that we did in the Department of Psychiatry at West Virginia University before I left, in looking at rural healthcare providers' compassion fatigue, in particular during the COVID-19 pandemic, and some of the work we were doing to actually address that at that level. So I want to start by defining compassion fatigue. I'm going to go back to this picture. This is also located within the New River National Park, and this is actually from Grandview. It's a quite spectacular aspect of the park as well. As you can tell, I like to do a lot of camping and hiking, which has been a real advantage of my time in West Virginia. So compassion fatigue, for those of you that are not familiar, is a combination of basically traumatic stress, secondary traumatic stress, and burnout. It's common among people in the helping professions. It impacts not just the quality of care of these healthcare providers that they're giving, but also their personal, physical, and mental health at their job. And in some, it's been described as the emotional, physical, and spiritual exhaustion from witnessing and absorbing the problems and suffering of others. And I'm sure with Vermont also being a largely rural state, that some of these themes may resonate among the clinicians in the audience. So I published this article, which was really entitled The Bell Tolls for Thee and Thine, Compassion Fatigue and the Overdose Epidemic. And really, it was actually a culmination of my experiences working on the front lines of the overdose epidemic during my time at the University of Cincinnati, where I started to work in the Southeast Appalachian region of Ohio prior to joining WVU, and really sort of seeing the impact that the substantial amount of overdose deaths is having in that community. In particular, I was sharing with someone earlier today, in some of these small rural communities, they've essentially lost a generation, right? And so you now have children who've lost their parents to drug overdoses, who are being cared for by their grandparents. And then, of course, in some unfortunate circumstances where they may have witnessed some of that traumatic, whether it was a fatal or non-fatal overdoses, can be a seriously traumatic event to witness. So building off of the really well-established field of measurement and conceptual development of compassion fatigue, really, I was looking to expand that to specifically include overdose-related compassion fatigue. And so set forth the definition of it as distress or reduction in empathy resulting from knowledge or exposure to overdose-related harms. So it may not just be overdose deaths. And really what you're seeing in play here is that you have the belief that services work. So prevention and treatment services can help people with opiate use disorders and other substance use disorders. You have this underlying desire, right, to help people, and then some sort of exposure. And here again, trying to emphasize that that exposure can be secondary. It's not always directly witnessing an overdose, but you may come to know of someone. And that might be someone who, if you're in the healthcare profession, it may be someone that you're treating. It could be one of their friends or family members. It could be someone you know directly. And actually, even for those of us that work in the field of addiction science, and if you're doing clinical trials, you often may experience participants who actually will die during the course of the trial, often not related, of course, to the interventions. But they may experience an overdose during that time. And so really looking how that impacts the development of secondary trauma and burnout. And I think the way that's manifested in my professional experience working with communities, rural communities across the country, is a lot of frustration in why we can't help people recover, especially for those working on the front lines of the overdose epidemic. And the frustration can really be with the people who, if you think about EMTs who try to help people and don't understand why they just don't stop using. But also, I think for behavioral health care providers that are frustrated, right? They know what can work. They're doing the best they can. And maybe they don't have the volume, or they don't have full wraparound services, or they're not able to have co-located services. Or as we know in rural communities, there's long waiting lists to actually get into treatment, or they want treatment, but they have no transportation to get to those treatment services, or they have no people who can watch their children, right, so that they can get into care. So all of these things that complicate it from the service perspective can cause frustration at multiple levels. And the consequences of compassion fatigue can really exist at the individual, organizational, and community levels. So we've spent in the field of compassion fatigue probably a lot of focus looking at individual and organizational consequences. So again, that's really think about health-related problems, burnout, lack of empathy, hopelessness or helplessness. In West Virginia, there is in general, when you think about West Virginia as having the highest rate of overdose deaths in the country for over 20 years, there's a significant amount of discussion around the lack of what hopelessness means, right? So 20 years trying to reduce overdose deaths with limited to no success. The most recent data actually does suggest that it's leveling off, perhaps declining. It's just not clear if it's returning to pre-pandemic levels, right? COVID pandemic levels, or it is a true decline. Time is still gonna, will tell what this slight decline it will mean, but also can result in lower healthcare professionals delivering lower quality care. The organizational level, we see a lot of burnout. And that was particularly problematic for our healthcare systems, where people were rural behavioral healthcare workers were burnt out before COVID. And it certainly only got significantly worse. And the ability to take time off became extremely challenging during that time. And we lost, again, a lot of people left the field. And we've seen this time period as one of the greatest exodus from healthcare, sort of across the board because of some of these challenges. What we don't talk about as much, though, is the potential community impact, and really seeing the role, particularly in rural areas, why of it potentially increasing stigma, the sort of decreased belief that recovery can happen. And again, in small rural communities like West Virginia, you can see how this happens. 20 years, you've allocated financial resources, you've expanded buprenorphine treatment programs, you've had major naloxone distribution through SAMHSA funding, and yet overdose deaths continue to increase. So it's been very frustrating to understand that. And then blaming individuals for their use or their lack of motivation to achieve recovery, and then seeing if that actually manifests for decreased support, right, for expansion of these prevention and treatment programs that we know work. In terms of its impact on the workforce, we already mentioned, right, that, clients die, clients, friends, and families die, and colleagues, friends, and families die. At the onset of the COVID pandemic, our department did experience staff members who died during this time, and it really took a significant toll on our staff. And then you sort of have to balance this with this concept of moral injury. So we know that moral injury is a strong cognitive or emotional response to an event that violates one's morals or ethics. And it can cause feelings of guilt and shame, feelings like I'm a failure, my employer doesn't care about me, and a loss of trust. Sometimes the way that this manifests, which I'll talk more at the end, is sort of this idea of, organizational responses will be, you have employee assistance programs known as EAPs, or they may offer a yoga class during your only 1 hour lunch break. And or we've offered these services to you, wellness services, and you're not willing to take advantage of them. So hence you are to blame for your own compassion fatigue. And that really contributes to moral injury in this case, and sort of makes it worse when we blame the folks that in fact are pretty frustrated with it and trying actively to manage that, and there's a lack of recognition of the extent to which the organization or structure of behavioral health care has contributed to that risk. So I realize in a large setting that's primarily online that these questions, we won't actually have a discussion, but what I would invite in particular for audience members and for folks joining us on Zoom, you could potentially drop it in the chat, and when we get to the end, we can loop back to some of these questions. But the extent to which someone who's died of a drug overdose, when you ask this question in Appalachian regions, it's very hard to find someone who doesn't know someone, and I'm assuming that would be maybe the case here as well. So I want to talk a little bit about the factors that fuel overdose-related compassion fatigue. This is a picture of the gristmill at the Babcock State Park in West Virginia. This is one of the most photographed gristmills in West Virginia. I had the pleasure of actually getting this picture at the tail end of fall. I will say I grew up in Connecticut, and I do dearly miss New England in the fall. And but trying to capture this picture and edit out all the people was pretty challenging. So it's very hard to get close to anywhere where the traffic is incredibly bad. So some of the factors that I argue are fueling compassion fatigue is this continuous increasing death rate despite efforts, as I already mentioned, to prevent overdose deaths in the case of widespread distribution of naloxone. And of course, we know that's because of as those efforts were taking place, we saw more novel, highly potent opioids come onto the scene. And now, of course, a lot of illicitly manufactured fentanyl that sort of complicates and increases the probability of overdose fatalities. It's really taking an impact on families and communities. We see a depletion of financial resources and competing demands. What we saw in areas of Kentucky, you have communities that say they get frustrated because they have spent significant town or city resources on overdose prevention, distribution of naloxone, training of their frontline workers, and are actually saying that they are depleting resources that they need for other things, to buy basic equipment for the police or for the fire department. And so that really creates a situation where these competing demands for resources puts those things juxtaposed and creates challenges. And also, significant problems in linking clients with timely and comprehensive services. So when I moved to West Virginia University over 8 years ago, our outpatient buprenorphine treatment program had over 450 people on our waiting list. So where were you going to connect people? It's fairly well known anecdotally in regional communities, particularly as you get outside the greater Morgantown area, that there is no public transportation system in West Virginia. Even that exists in Morgantown is very difficult and hard to manage. It's not like a typical city public transportation system, bus system. And so you really can't get to treatment unless you move closer into the city of Morgantown to actually get treatment. It can be very challenging outside of that area. And of course, we have stigma as well. So I've already mentioned this, that overdose deaths have increased in West Virginia for over 20 years. It's interesting now to note that they lead not only in opioid-related overdose deaths, but also in psychostimulant-related overdose deaths. We've seen a significant transition probably in the past 5 years of really increasing rates of methamphetamine use that have really complicated our ability to effectively provide treatment. So I think you're probably all aware that overdose deaths are increasingly involving psychostimulants in the more recent years. What hasn't gotten also much attention in the empirical literature, or actually even in the media, is really the impact that the overdose epidemic has had on families and children. So we know that we've seen increasing rates of opioid poisoning accidental poisoning among children. But of course, there's this aspect of family dissolution, right? So whether the parent dies of an overdose or perhaps goes to jail or prison due to a drug-related charge, this is causing a significant burden in terms of grandparents that probably thought they were done child rearing, having now to take on that new role, having a lot of significant challenges in actually navigating the custodial system, right, to actually be able to access benefits for their child care. And really shockingly, West Virginia has over 6,800 children in foster care. There actually is a foster care crisis right now. The federal government was actually suing the state for their treatment of foster children. There's not enough foster homes. And you can see this as perpetuating potentially exposure to trauma across the life course, and really just a complete inability to help these children that are impacted. And so children are actually also witnessing fatal and non-fatal overdoses. I had a mentorship with a graduate student of mine at WVU right before I came. I was talking about this talk that I'm giving today. She wasn't aware of my work in this area, and she works as an EMT in the Morgantown area. And she, is frequently responding to very difficult situations where someone may have experienced an overdose death, or as she mentioned, what's really particularly disturbing is she described, seeing children in the house that had witnessed this, and actually coming upon a child who had Narcan in their hand and said, "I didn't know what to do." So that's just really heartbreaking, right? And so we know that we see expanding efforts to train children in the use and availability of naloxone, also how to call 911. But it's really heartbreaking to see these situations where kids don't necessarily know what to do. It's also quite tragic that they have to know what to do, right? So it puts a lot of responsibility on them in terms of having to grow up pretty quickly. And in terms of overdose and trauma, opiate use disorder and trauma, we know that our patients who are in treatment for opiate use disorder have significantly higher rates of having experienced adverse childhood events during their childhood. We think, of course, that they've also continued to have potential repeated exposure to trauma across the life course, which of course is accumulating. We did a small study in our buprenorphine treatment program to look at gender differences in ACEs in our buprenorphine treatment program. So while nationally we see about 12% of folks experiencing childhood abuse, sexual abuse during their childhood, in our sample, we found that almost half of the women and 18% of the males actually had experienced sexual abuse before the age of 18. Again, that's not including what happens afterwards. And actually, strikingly, in our inpatient acute dual diagnosis unit, it was actually over 50% being exposed to sexual abuse. So we see a lot of trauma in this population. Go ahead, thank you. Mental health and substance use disorders. It's an acute care, so they usually it's a very relatively short stay of 2 to 5 days. Thank you for allowing me to clarify that. So, it's interesting, there's not as much media coverage of this in West Virginia, which is a bit ironic. But while it was in Ohio, this was frequently in the news. And this is really speaking to how does the community get impacted by overdose-related compassion fatigue? How are they exposed or actually could potentially have this sort of secondary traumatic exposure to these events? And that's because it was frequently in the news. This one case actually in particular did make the national news. It was at Cincinnati Children's Hospital. There was a child in the hospital. Mom overdosed in the bathroom and died while their child was in care. And the dad was actually arrested and went to prison. So this person, this poor child, right, who actually has a serious medical problem now, has essentially no parents. We also saw a lot of attention around people who survive overdoses temporarily. And so in the situations where we suspect that someone did not respond or find them soon enough in terms of administering naloxone or actually transporting them to the hospital, that oftentimes they have systemic, because of the lack of oxygen that occurs during an opiate overdose, that they have lack of oxygen to their major organ systems. So we think they experience severe traumatic injuries to the brain and other parts of their body, other organ systems. And often the parents are left to make the difficult decision about when to end life support. So, just as a quick reminder of how frequently this has happened, we think something like most overdoses at this point are survived. So people often experience non-fatal overdoses. And again, if that's not administered in time, there could be a significant amount of morbidity, which is another related area of research that I'm working on. So I really love having someone who's done a significant amount of work and doing community-based work through my role in the Clinical Trials Network and other research projects that I've been involved with. It's really difficult to describe the human suffering that's occurring associated with the opiate epidemic. And it's interesting, I was trained, as some personal aside, I was trained at Johns Hopkins, right? So I feel like I was trained to be this really objective, somewhat devoid of emotion scientist. And then I find myself working in these communities where there is just completely these heart-wrenching phenomena of drug overdoses or families that are being experienced. And I'm sharing these statistics about what is the level now. It's over 100,000 overdose deaths in the country. And it's just sort of we sort of gloss over those numbers, right? So we've heard them for so many years now. And it's a very difficult or easy to sort of depersonalize those numbers and not really understand how many people are impacted, and really starting to look at art to see where you can sort of understand more efficiently. And it's really sort of changed how I communicate and try to connect with communities around describing the suffering, because the numbers are really don't do a very good job. And so I guess Dr. Volkoff agrees with me and has actually invited William Storr, who's an artist, to actually present. And you can actually Google his name, and I think you can have access to the video presentation that he gave at NIDA. And so he's this wonderful artist and really talking about stigma and being able to portray some of the suffering associated with that families and individuals experience. So his sister, named Emma, was struggling with an substance use disorder. And so he really sort of at one point has this really telling story where he tried to make a bargain with her to paint her portrait if she would actually go into treatment. So it's just an interesting sort of thing. But again, I don't know how many of you attended the College on the Problems of Drug Dependence last year in Colorado, Denver, but he is actually located there. And there was a side trip to visit his studio. His productions are quite large. So these are very compelling, emotional pictures. And I really think he's done this fantastic job at capturing that emotion that he's experienced as a brother of someone who struggled with substance use disorder. And unfortunately, his sister did succumb to an overdose death. So one of the other aspects of this is that we see that there's really limited treatment capacity. So, and this is the thing that can be quite frustrating is, from a public perspective, we see that the individuals who suffer with substance use disorders, there seems to be sort of this idea that they're not taking the responsibility to seek out treatment. But in fact, we pay very little attention to the fact that there actually is a crisis in access to care and that gap. So if every single treatment this is Chris Jones' work that was published in the American Journal of Public Health, where he really sort of shows eloquently an empirical way what this limited treatment gap is basically saying at this point in time in 2012 that even if every single buprenorphine waivered prescriber and opioid treatment program maxed out the number of patients that they could treat, that in fact there would still be a significant gap in the number of individuals, inability to treat every individual that's estimated to have an opiate use disorder. The counter argument that you often hear is that not every one of those individuals is actually motivated to seek treatment. And I think that that's variable over time, right? So, but at the end of the day, we need to have the capacity, we need to have timely, easy to access treatment. And often we're seeing that manifest now as in more research on low barrier, low threshold treatment or services in order to help bridge this gap. So again, we know that maybe estimates suggest that about a little more than a third of people may not be ready to stop using drugs, but that doesn't mean that we don't offer those services to them and or see this expansion rate of harm reduction. If we can't keep you alive until you're ready to get treatment, then that treatment ultimately will have very little value. And of course, I'm sure you're all aware of the really phenomenally low rates of access to substance abuse treatment. So you think probably less than, 15, 17% of those who need treatment are actually able to successfully engage in treatment. And we do know that obviously individuals residing in rural areas have significantly less access to medications for opiate use disorder. And the media doesn't help us often. They're not really our friend in this. There's been some somewhat limited coverage of people with opiate use disorders and some empirical studies of what kind of news coverage is happening. And really what you see is some inaccurate portrayals, which is probably not surprising. And also not seeing that sort of positive reinforcement around what the benefits are of medications for opiate use disorder, which is quite ironic because the pharmaceutical companies have had such, I think, success rate and sort of destigmatizing medications for mental health or depression. I'll never forget when I first went to a neighborhood cookout and people were openly talking about their depression. And I was like, where am I? You don't know me. And, but again, trying to sort of destigmatizing things and opening it up to be able to say, I'm using X medication, it's helping me, and feeling like they can talk about that openly. And I think it's sharing of those positive experiences and that lack of stigma that actually helps to create an environment that's supportive of people taking medications for opiate use disorder. So there's a lot of myths around people using drugs, that they actually don't want help, that addiction is a choice and not a disease. They don't think they're deserving of help. They have flawed characters and poor morals. It's really sad is that I think there's a lot of people who give lip service to believing that substance use disorders or drug use, is a brain disorder, but they don't actually act that out in practice, right? So I think this rhetoric is lining with where they think they need to be, but sort of not understanding the challenges that people encounter, but also just not understanding how difficult it is. So I've done a lot of work in conservative rural areas where there's low uptake of medications for opiate use disorder. And I've often given the example of I have asthma and allergies, and I go I used to have to go weekly, right, for injections for my allergies. And no one's ever said to me, Erin, when are you going to stop those injections, right? I was never got pressure. No one was like, hey, you need to stop, right? No one looked at me as a moral failing because I needed to get these allergy shots. And it's really unfortunate that we're not at that situation or anywhere near that in the case of individuals with substance use disorders. So we do have actually really strongly developed, widely used tools with good psychometric properties to measure compassion fatigue. So we have the professional quality of life scale for those of you that are interested. It does generate compassion satisfaction subscales for compassion satisfaction, burnout, and secondary trauma exposure, along with some other instruments. And so we actually, as part of my work on overdose-related compassion fatigue, I actually based that on the PRO-QOL and actually did some preliminary testing of this instrument in a convenient sample of individuals that I was working with in another capacity. And what I found on this instrument is that I had in the audience about 50% who had witnessed an overdose, and about 38% who actually knew someone who had overdosed. So seeing really high levels of exposure to direct or secondary trauma. And really what I was able to demonstrate in a slight modification of the PRO scale is that actually much higher rates of compassion fatigue among those respondents that had witnessed or experienced or directly witnessed or learned of someone's overdose. This is just a cross-sectional survey. It's not really strongly generalizable, but it's a first hint or some pilot data to suggest that this is a true phenomenon that's occurring. So I think you don't even have to answer in the chat, but maybe just think to yourself, you know, in terms of this polling question is, I think that I might have been affected by the traumatic stress of those that I help. This is an interesting question because as I wrote that article, you know, I am non-clinician scientist, but I will say I actually feel that I was working in these highly impacted areas. Even as a researcher, I was impacted, right? I have trainees who were collecting data in an emergency department outside of Cincinnati that were witnessing some pretty difficult things. So having to think about, how does this impact me as an individual? How does this impact my trainees? How do I help set up in place a system to help manage the things that they're exposed to? Certainly for some of our younger trainees who perhaps come from very strong families and social support networks and sort of are not familiar oftentimes with how other family members may treat individuals with substance use disorders, and hearing some of the really difficult things that are said in healthcare settings and sort of understanding how do you deal with that. So it's something I found even personally I was starting to struggle with. So we sort of know these things are happening, but what in fact can we do to build resilience? We can't just go to the gym, right, and build these strong muscles, but there are some things that we can do, although there's still much work to be done. So we know from neuroscience, research on the neuroscience of empathy, that this, as I found completely fascinating, right, is that in fact, they see in these studies the same areas of the brain are activated when we have empathy. And that's whether they indicate the presence of empathy, rather, whether they experience their own pain or they see someone experiencing pain, that they're actually seeing the same parts of the brain light up, which is giving us, again, some sort of biological verification that this idea of secondary trauma is valid and is impacting us from a physiological standpoint, not just something that might be reported as a psychosomatic event. We also know too that there are, many people go into the helping professions because they are empaths. So they like helping people, but that's really hard to sort of balance that, where I want to help you, and I can do that because I'm empathetic, but at the same time that may make me vulnerable to this idea of the secondary trauma. I actually am really glad that I'm not a clinician, because I am maybe too empathic. And so that would be really difficult for me to manage. So I'm really glad that I am a non-clinical scientist. So some things that we know that individuals can do is really focus on evaluating the employee's wellness, addressing compassion fatigue during your supervision, And again, I think we think about this mostly in behavioral health care professionals, but the extent to which we can do this on our research projects, especially if we have a highly, are we working with study participants that have lots of exposure to challenging situations, understanding the role of self-care and stress reduction and mindfulness. In terms of some of the workplace strategies, and this is what I was involved with doing at WVU before I left, is we actually looking at using standardized tools to actually measure the extent to which this is a problem and actually interest in what wellness resources they wanted or don't want. Also trying to understand how we address compassion fatigue and integrate some, what is it, peer support? We use peer support programs in our clinical research or interventions, but what does that mean in the workplace setting? And also looking for evidence-based strategies to help. So one of the things that actually does work, and I talk about this in my article, is actually this concept of vicarious resilience, which I quite love. And so, just as we can experience secondary traumatic exposure, right, where someone shares a difficult situation and we have this empathy with that situation that impacts us, the same can happen when they achieve success, right? So, it's the positive experiences of witnessing people who have positively adapted to the past or current adversity. Since we're in Vermont, I'm sure you may know this story, these amazing stories of people that were impacted by the Boston Marathon bombing, who have had significant medical consequences, the loss of limbs, who go on to do things like Dancing with the Stars, right? And so these stories just give us amazing sense of hope. And I think many of us know that there are higher rates of potentially compassion fatigue and stigma in frontline providers, particularly in cases where it's like the EMT or emergency departments, because they see the negative consequences of addiction, but they often don't get to see what addiction recovery looks like. They don't get to see the mom when not only does she stop using drugs, but she gets her kids back. She gets a job. She restores all of those family and social connections that were lost during that period, and seeing someone radically change their life. And in particular, in cases where someone had multiple overdoses, had multiple treatment failures, and yet somehow that 5th, 6th, 17th time they tried, it actually sticks and their life changes. And even if it's not as dramatic as, complete cessation from drug use, but really seeing significant reductions in risk, right, that protect their health and that protect their family and their overall well-being. And not being able to see that is really difficult. And I think during COVID, a similar sort of thing happened. When you are a non-clinical scientist, I didn't get to see and hear those stories, right? And so it's really, and even on different settings of care that you live in, you may not get to hear those stories. Or more importantly, sometimes we just focus on sort of the negative without remembering that one person that you did connect with services, right? And in rural areas, oftentimes we don't see this dramatic change, but what we do see is small changes. I got you into treatment. You're able to come. You found a way to pay for that. You got a part-time job, right? It's not what you ultimately want them to achieve, but they are small steps. As Dan Big used to say, it's any positive step can be important. So really we can start to look at how we can transform our empathy, where empathy allows us to see the other perspective. And so transform it and regulate your emotional empathy to transport it into compassion, and actually integrating these self-care and wellness strategies. So I want to talk just very briefly. So do you want to allow some time for discussion about an applied example? So I'm not sure if you know, but West Virginia has some of the best whitewater rafting in the country. Actually, people come from all over the world. So of course, when I moved there, I had to do whitewater rafting, which then I subsequently found terrifying, because you find yourself in a boat with people you don't know, and your life depends on working together as a group. So in this particular picture, this is my family members, and so I can trust them most of the time, but we went again with a bunch of strangers and it was terrifying. So I definitely say proceed with caution. So what we did in the Department of Psychiatry during COVID is we actually formed a Healthy Healers Committee, and it continues to be ongoing. And we've actually recently just published some of our work in this area that I'll be describing. And so we essentially did this. We compiled a needs assessment survey that did include a shortened version of the PRO-QOL to measure compassion, fatigue, and satisfaction. We were really working towards creating a culture of wellness, which to this day I think is quite difficult. We did enter some things. I'm not sure what strategies you may have used during COVID, but I actually still really like this idea of starting to talk about gratitude. And really what we were doing is capturing on this idea of vicarious resilience and trying to share some success stories, right? Of some patients, research participants, even systematic or process level things that have happened, so we can share them with them and more people sort of get exposure to that in the setting. And also it's a great way to sort of end meetings, especially if you are brainstorming some difficult situations, you're having problems with study recruitment or other challenges, and it's really easy to get bogged down in those challenges, but just sort of take a step and say, let's share some success or wins for the day. And you can really sort of, especially at the end of meetings, sort of change that shift that people are going to be leaving with. We really tried to look at expansion of employee assistance programs, both through the medical center and through the university. We actually offered some really quick support system because oftentimes people were in crisis because these crises were occurring a lot during COVID, and trying to have immediate support for people. So in terms of, this is the work that we actually just published. And so we actually found during 2 waves of surveying the Department of Psychiatry and Medicine at WVU, we found, not surprisingly, that 38% of our respondents, I should say this is not just direct healthcare employees, this is everyone. So it could be administrative staff, it could be leadership, it could be faculty, it could be trainees, and it could also be clinicians. And so we saw about 38% screen positive for anxiety, about 1/5 screen positive for depression. And very few people actually used EAP. I think this is a really important message. They were not into EAP. Like 4% is dismal during COVID. And the unfortunate part of EAPs, if you're not familiar, employee assistant programs, they're often really just bridges to more formal treatment. They can be temporary. They should be really low threshold, right? Like it's pretty easy to access these. I'm not sure if there were fears of anonymity, that it was not anonymous or that people could get access to that, or I'm not sure what other barriers there were. But people were not using it. What they did use, which I'm not sure this is a therapeutic intervention, we actually developed a Coping with COVID Facebook page. And that's actually where a lot of this activity was happening. And so that was pretty interesting to actually find out. We actually said, okay, well, you're not using AP. What do you want? And so they wanted overwhelmingly time off for self-care. So I think it's really important. Food trucks. People love food trucks. You might have a nice selection of food here in Vermont and Burlington, but we definitely do not have as many options, and it's quite difficult to get off campus and then try to fight for parking again. But I think what we really found that's important is there is some autonomy in the process to identify, right? So it's not structured programs so much, but I will give you time off, and you as an adult will exercise autonomy in choosing to understand what you need to do for your own wellness. So in West Virginia, this manifests for things like perhaps going to a faith-based, your faith-based organization, going fishing, going hunting, walking in the woods, knitting, just a lot of that autonomy and you figuring out what's best for you. A lot of our young trainees like to play video games, whatever it is that you need to do for yourself. But they also loved animals. So having more support animals. There was, I thought, going to be a riot when they decided that the dogs were going to could transport, pathogens in the hospital, and they were removed. And, that was really distressing. What's turned out in the process of publishing this paper, which is not explicit in the manuscript, is I think one of the issues with the availability of support animals on our acutely impacted units is it's not always the time and place to dive deeply into what's going on emotionally with the person. It's too much to unpack in a short amount of time. But what they can do is connect with this animal and sort of have that experience in a way that was supportive in that specific time period. So since then, the department, I think, had some sort of pony come on campus and lots of other things going on that are creative. So I think what's interesting in this sort of almost post-COVID period, is there's really still this idea of beyond burnt out. And also, you do not have to proclaim this yourself, but also this idea at some point that there's still a little bit of languishing going on. And so it's difficult time to talk about because, you know, we think the worst of the pandemic is over, but we're still sort of having these experiences. So I really love this, again, going back to this sort of art theme that you see throughout here. And it's really speaking to ways that we can potentially build into a community level resilience. So Claudia LaBenca in Jackson Memorial Hospital in Florida created murals to recognize the work that our healthcare professionals are doing. And I think that this is one of the challenges is that rural behavioral healthcare workers, if there is lack of support for medications for opiate use disorder, and that is what you do in your job, you may not be able to go to your community friends or other community events and have support for what you do. Like, your work is important. Oh, I'm so glad you're doing the work. Instead, you may hear things like, why are you enabling people's drug use, right? And so not only are you not getting supported in the workplace, but now you're going into your communities, and that's making it much more difficult. Whereas here, we're trying to see what can we do at community level interventions to actually support this and create communities that are supportive of healthcare providers, and trying to think about what's the analogy for reducing stigma and having more community resilience towards individuals with substance use disorders. So, in the sake of time, I'll just sort of briefly say, what are the things that I think about in envisioning the future? And it was really sort of one of my intentions in writing this article on overdose-related compassion fatigue is really to just talk about, as individuals, what is the emotional cost of this overdose epidemic? And I have had a significant amount of people from around the country reach out and thank me for starting to give a vocabulary, right? That this is real, what your experience is real. And it's not specifically measured on existing instruments. And really trying to understand structural factors that can contribute to this, and that we actually have a shared responsibility to actually support employee and creating safe environments. Right now, the way that that's in my new division, this is really becoming under this idea of psychological safety, right? And the reason that I think appropriately so, organizations, academic medical centers, and other actually non-health care businesses are really starting to focus on psychological safety and wellness is because it's linked to retention. And it's also linked to better performance, better job satisfaction. You know, happy employees stay and they do a better job. But we really need to do more to actually understand how to translate those to community level interventions, particularly for those residing in rural communities, and actually try to build hope that recovery happens. So here are just a few more pictures of my dogs in West Virginia, and of course my contact information. And if it's okay right now, I'd like to take the last couple of minutes to hopefully hear from some people in the chat and people in this room in terms of questions to ones that I've raised during my presentation, or if there's any other things you'd like to discuss.
All right, thank you for that great lecture, Erin, and there's plenty of time for Q&A. And those who are with us online, please send in your questions or comments.
Yes, thank you. One of your slides showed a picture of the United States with the states colored in different colors. I couldn't quite read what that was about. I guess it was showing states of prevalence of this sort of problem. There we go. If you could just kind of hit the high points of that one.
Yeah, I'm sorry. Thanks for allowing me to come back and explain that. I apologize. The darker shades of green in this case represent states that have higher overdose death rates. And then as the color fades, they have lower rates of drug overdose. In the granularity of this picture, you don't see it as well. That West Virginia is the highest, but you are seeing this clustering, right, of states in New England states, of course, and then also this Appalachian region of West Virginia, Kentucky, Ohio, Indiana, Illinois, being highly impacted. And this is from the CDC in their 2020 overdose death rates. Of course, we know there's always a lag in reporting the death data. Thank you.
Thanks for a great talk. Really appreciated connecting the emotion back to the data. The slide you put up around how the statistics don't necessarily convey the emotion really resonates with me. My question is about predictors or maybe moderators of overdose-related compassion fatigue. I'm wondering if you've worked on, or if you know if anyone has worked on, whether pre-existing beliefs about addiction or stigma related to addiction have any impact on subsequent overdose-related fatigue, whether how we view addiction might affect how susceptible we are to fatigue if we work with people or experience overdose.
I don't think there's any data on that. There's no empirical data. I think what we do, there is empirical data that actually there's quite a bit of research on looking at physician or clinician characteristics associated with uptake of buprenorphine. And what we do know is that those that had more negative attitudes towards buprenorphine and negative attitudes and beliefs about individuals with opiate use disorder, that actually exposure to patients, direct exposure to patients with opiate use disorder as a standalone intervention does start to shift and move the needle. So I think oftentimes there's these pre-existing beliefs that are not based on interaction with individuals with opiate use disorder. So like a fear of the unknown almost. And so it does appear that and that's why in part you do see a lot of training new clinicians on the use of buprenorphine does engage some sort of interaction or practice with patients in recovery to one, get direct skills in interacting with these participants, with these patients in this setting, and to gain the skills, but also to realize that maybe they're not that scary, right? Like your beliefs might not actually manifest, but there's not any sort of empirical data directly, but of course there's sort of reason to believe that could be true. But I do think this is really an accumulation of my professional experiences and some curiosity that I have, and in part because I know some of these people individually as friends who work in these frontline positions who I know are not bad people, who have very unfortunate opinions of people who use drugs. And I do think in part it's repeated exposure to seeing the kids in the household, right? Repeated and the inability to emotionally articulate what's happening. So there's a good movie that's called Heroin with an E. It's on Netflix. It is actually a documentary from West Virginia. There's like my favorite part of the movie is this really small clip where she pans in on a firefighter in Huntington, West Virginia. And they're talking about how firefighters used to see, maybe one death in, 5, 6, 10 years over their career, but now they're starting to see deaths once a week, once every other week, and it's people that they know. And so the director says, how do you deal with this? And he says, I go home and drink. But so it's not this, you don't see a lot of emotional articulation about what's actually happening, but you see reactions to that, right? So that's the toll it takes on him, or just sort of this idea that people can't recover. So, but that process itself, I don't think has been well articulated or studied. Does that answer your question?
We have a few questions from online. So the first one is, how are rural communities uniquely able to address the barrier to care?
I don't know. So that's a great question. I actually took out some slides that I had on this topic. And I don't know what the situation was here in Vermont, but actually West Virginia had incredibly high rates of initial rollout of the COVID vaccine when it became available. And I think part of the reason that they were successful is in smaller communities, you can be creative in how you roll out programs, right? So what did they do? They deployed nursing students at all of the universities and pharmacy students and put them in cars with vans with the vaccine and went to communities. They were creative in overcoming regulatory barriers to doing this, or they were able to quickly implement some temporary orders that would allow a regulation, flexibility in regulations to allow this to be quickly deployed. They can be more flexible. You often see they can come together during difficult times. They're less constrained by complicated, large organizational systems that, you know, inherently move quite slow. And I think that's it. And I do think what you do see in the case of the movie, like Heroin with an E, is Jen Radar is the actual first female fire chief in the state of West Virginia. And you do have these personal connections that can be incredibly persuasive in making change. I know they're not sufficient, but I think you can have some. It's one place where you can have a community champion that can have a different impact, but also not only in the extent of being a respected leader in the community and having that potentially influence change, but also as someone who knows how to work backroom logistics to make these sort of changes happen potentially. But I'd love to hear if there's things in Vermont that have happened that are akin to that.
Yeah, we have another one online. They ask, is there any data on how lack of funding to support treatment affects compassion fatigue?
Not that I'm aware of. I do think there's been there's discussion professionally around, in particular in the context of methadone treatment, that the challenges in not only the limited funding available in that system in particular, but the fact that there hasn't been increasing rates for reimbursement. Also, these challenges. So how does, you know, inflation continues to occur, and yet from an organizational perspective and a billing perspective, that the rates haven't increased to sort of ensure greater provision of services.
And kind of another question that kind of goes along with that is, to what extent may the increasing supply of fentanyl be contributing to that compassion fatigue?
I think I feel like I sort of witnessed that firsthand, particularly in my work in Ohio, is that we really saw in some regions, you really saw that this complete intersection of widespread distribution of naloxone appearing to be counteracted by increasing rates of overdoses related to fentanyl. And so that really created this situation that sort of really complicates things. When I first moved to West Virginia 8 years ago, there was one of these sort of, I don't know, it's not quite calling them mass overdoses, but essentially it was something like 25 people overdosing in a, you know, less than 24-hour period. Fortunately, many of those people were saved, but that's exactly what it was. It was sort of this new influx of a particular suspected to be fentanyl that led to this sort of mass situation that was really stressed. The rural healthcare providers don't have good capacity to expand to those sort of events, right? They don't have enough ambulances. They don't have enough life support, you know, machines and mechanisms of that. And so that becomes really challenging.
Awesome. And we'll end on kind of a more positive note. So someone online asked, or kind of stated, I'm curious what your recommendations are for supporting peers within the workforce working in rural areas where the community they work in, may have been where their prior use had occurred. So people who are still living in their communities.
Yeah, thank you so much for that question. I think that's incredibly important, especially for our research investigative teams. It's something that I rely on my colleagues that are clinician scientists. But I think what we're doing is actually also looking to partner with organizations that actually peer recovery organizations that have appropriate or structural things in place to allow for peer supervision, and also the idea that you can rotate through peers, right? And having closer supervision. But I think the science on the organization management of peers, and I'm not saying that in a negative way, but to protect individuals that are in recovery, right? To really understand, how do we optimize that? How often should they be? What can we do in particular situations that may be a trigger, and have appropriate management of that, is something that I strongly believe. And we've actually encountered some pretty challenging situations in our own research that really suggest that we need to partner with really good organizations that know how to do this.
If you're willing to indulge one more, first off, great presentation. I'm curious as to why West Virginia is leading the nation in so many of these negative categories. So what is it that is contributing to the problems that is unique to West Virginia?
I love that big question. I cannot answer it in 1 minute, but let me sort of tell you what I think. I think it's a really complex combination of issues, but let's talk through some, we could talk a lot about exposure to trauma. That's what I argue in one of the papers that I shared with you. Certainly, I think lack of provision of early mental health services for children. I do think that one of the issues is you do know right now that despite 20 years of an overdose epidemic, that there's a moratorium in West Virginia on methadone treatment programs that limits, there's only 9 methadone treatment programs. So we have 2 things that we know from numerous research and meta-analyses that, methadone and buprenorphine reduce overdose risk, death of risk by 50%. It reduces all-cause mortality by 50% and death by suicide by 50%. And yet there is a moratorium in West Virginia. There has been significant expansion of buprenorphine, but there is still unbelievable stigma towards medications for opiate use disorder in West Virginia. We have residents that we've trained that try to go back to these communities in which they grew up and open buprenorphine clinics, only to have complete towns rally against them and say, not in our backyard. And we also have the inability to consistently scale up harm reduction services, again, because of the politicization, is my explanation of what is known. We have evidence-based services that we have proof that they reduce overdose deaths and help people achieve long-term recovery. Unfortunately, the politics and economics make them difficult environments to do what we know works. I think this is, undoubtedly. And I think that, the one other thing to be fair is that there historically in the situation with opiate use disorders is that there is this intersection of chronic pain and opiate use disorder that exists. So inadequate access to legitimate pain care, inadequate financial reimbursement for, again, legitimate evidence-based services to manage pain, more extractive industries, so lumber, mining, that increase the rate of injuries occurring or painful conditions, contributed to it. And but it is also, and then of course there was, a really clear pipeline where these illicit pain clinics in Florida, they actually had really cheap flights into Huntington, West Virginia. So it's a really clear pipeline, right? They're coming up the highway. So there's a sort of drug distribution networks too that play into that. But that's a great question. And so that's sort of my opinion. People have very different opinions on this topic. But thanks for that.
Well, I think we're out of time, Erin. Thank you for just a terrific talk. Something on the scale of the U.S. opioid epidemic has so many dimensions to it, and you address one that's really important and overlooked. So I really appreciate it, and so thank you. Thank you. And then thanks to everyone who's online, and hope to see everybody in April. Thanks.